For this presentation, I discuss a pediatric case involving new onset type 1 diabetes that is complicated by diabetic ketoacidosis, or DKA. This case highlights how autoimmune destruction of the pancreatic beta cells leads to insulin deficiency, metabolic breakdown, and life-threatening emergency when left untreated. The patient is a 9-year-old boy with 3 weeks of polyuria, polydipsia, fatigue, and unintentional weight loss. Within the last 24 hours, he developed vomiting, abdominal pain, and rapid breathing. Family history is positive for type 1 diabetes and thyroid disease. On examination, he demonstrates Kussmaul respirations, fruity odor of the breath, dry mucous membranes, and delayed capillary refill. Vital signs show a heart rate of 130, respiratory rate of 28, blood pressure of 92/58, and serum glucose of 486 milligrams per deciliter. This is consistent with dehydration and metabolic acidosis. Differential diagnosis included diabetic ketoacidosis, acute gastroenteritis due to the vomiting and abdominal symptoms, and sepsis due to hypotension and tachycardia. Severe hyperglycemia, metabolic acidosis, and ketonemia supported diabetic ketoacidosis rather than infection. Type 1 diabetes is an autoimmune disorder characterized by T-cell destruction of the pancreatic beta cells, leading to absolute insulin deficiency. Without insulin, glucose cannot enter the cells, producing hyperglycemia and cellular energy starvation. Lipolysis releases fatty acids, which are converted into ketones, beta-hydroxybutyrate and acetoacetate, causing metabolic acidosis. Respiratory compensation produces Kussmaul breathing. Osmotic diuresis from glycosuria causes dehydration and electrolyte losses, especially total body potassium depletion. This diagram shows a step-by-step cascade that leads to diabetic ketoacidosis. It begins with an autoimmune destruction of the pancreatic beta cells, which removes the body's ability to produce insulin. As a result, the patient develops absolute insulin deficiency. Without insulin, glucose cannot move into the cells or be used for energy. This leads to hyperglycemia and cellular starvation. Blood sugar rises, but the cells are unable to access that glucose, so they signal an energy crisis. In response, the body begins breaking down fat through lipolysis, releases fatty acids into the bloodstream. These fatty acids are converted into ketone bodies, including beta-hydroxybutyrate and acetoacetate. Ketones accumulate rapidly and cause the blood to become acidic. The worsening acidity results in metabolic acidosis, which triggers the body's respiratory compensation. The patient begins exhibiting Kussmaul respirations, which are deep, rapid breaths aimed at blowing off the excess carbon dioxide, raising the blood pH. At the same time, excess glucose spills into the urine, pulling water through it, osmotic diuresis. This causes major fluid and electrolyte losses, leading to severe dehydration and total body potassium depletion, which contribute to hypotension, tachycardia, and overall instability. All of these processes together produce the clinical picture of diabetic ketoacidosis. Understanding this cascade is important for nursing practice because nurses are often the first to recognize early warning signs of DKA, identifying polyuria, polydipsia, labored respirations, or fruity breath during triage or bedside assessment allows for faster intervention, earlier insulin therapy, and prevention of severe dehydration or cerebral edema. Knowledge of the underlying pathophysiology directly guides the nursing assessment, monitoring priorities, and escalation of care. Diagnosis is based on a glucose level greater than 200 milligrams per deciliter, arterial or venous pH less than 2.30, and a positive serum ketones. Electrolyte monitoring evaluates potassium shifts during treatment. Hemoglobin A1C demonstrates chronic hyperglycemia. Autoantibody testing differentiates type 1 from other forms of diabetes. Initial management includes IV fluid resuscitation, continuous IV insulin infusion to stop ketogenesis, and careful potassium replacement. After stabilization, children transition to basal bolus insulin therapy, continuous glucose monitoring, dietary carbohydrate counting, and family education focused on prevention and sick day management. Acute complications include cerebral edema, hypoglycemia, and arrhythmias from electrolyte imbalances. Long-term complications of poor control include neuropathy, nephropathy, retinopathy, and impaired growth. With consistent insulin management and family education, children can achieve normal growth and life expectancy. This case demonstrates how autoimmune beta cell destruction leads to insulin deficiency and DKA. Early recognition, standardized treatment protocols, and patient education are essential to prevent complications. From a professional nursing perspective, this case shows how nurses play a central role in both acute stabilization and long-term diabetes management. Pediatric nurses provide ongoing education to families, teach insulin administration and glucose monitoring, reinforce sick day management, and psychosocial support to help parents and children adapt to lifelong disease management. As a future advanced practice nurses, the ability to integrate pathophysiology with patient teaching and coordination of care is essential to improving outcomes and preventing readmissions. References include the American Diabetes Association, Standards of Care in Diabetes, 2024, Hockenberry and Wilson, Wong's Nursing Care of Infants and Children, and McCants and Huether's Pathophysiology, the biologic basis for disease in adults and children. Thank you.